So I'm going to kick us off. My name is Stacy Augusto. I help facilitate our community conversations for CFHA. These are monthly conversations based on kind of member feedback and hot topics in our industry that affect us. And today we're going to be talking about AI in PCBH or in medical care. That's artificial intelligence, which I feel like if you've been paying attention, we cannot get away from it at this point. This is a really, really exciting topic and also probably a little bit scary, right? That's how I feel about it. I'm really excited to sort of share some of the things that I pulled together around this. I pulled together a little summary for us just to kick us off. And then we have Dr. Ian Best, who will also be sharing a pilot project. Dr. Best, do you want to introduce yourself real quick?
Sure. Hi, everybody. My name is Dr. Ian Best. I'm a general pediatrician practicing in Morris, Illinois, which is a small independent hospital, about an hour or so, depending on traffic outside of Chicago. We have 82 beds, but we really have a very large outpatient footprint. We have about 28 satellite offices that range anywhere from steps away from our institution to 30 to 40 miles away, very much rural care. And so I am a member of I'm the pediatric representative on a pilot project that our institution is using to bring AI into specifically the documentation space. We're not utilizing it currently for clinical decision support. So in the outpatient centers, but also within our ER and our immediate cares are using it as well. And then I'm also one of the physician champions for our integrative behavioral health program, which is how I got tapped to be on this call with you guys today.
Awesome. Thanks for being here. If you are on the call, please drop your sort of name in the chat if you want to, sort of your role. That's super helpful just to see who's all with us today. Please drop in the chat or come off mute and ask any questions or any kind of like reasons you joined or things you're hoping that we talk about today. I will sort of get us a little bit. Thank you, Laura, for kicking us off. I will get us started with a little bit of a mini case study on how I prepped for this call. So I went to ChatGPT, which is, all of us maybe are using, maybe not. And I said, provide me a summary of all of the AI advances and subjects right now in mental health, substance use, and primary care. And give me the pros and the cons, give me any legal ramifications, any hot news tips like media that's been coming out about this. And I asked it for a quick summary. Then it provided me, and I also asked it to keep it condensed, because if you're using ChatGPT, it tends to be very long-winded, actually. So I asked it to keep it to 2 pages, and that provided me a summary that I could then download. So if you're not using it, I just kind of wanted to show what that looks like, what it provided me with. So let me know if you can see my screen.
Yes.
Okay, great. So this is the downloadable PDF that ChatGPT spit out for me. And here's the summary of what AI tools do for substance use and mental health care. So we have chatbots, text-based companions, digital CBT tools that offer 24/7 psychoeducation, low-intensity interventions. AI can help screen and predict. So algorithms that flag patients that may be at higher risk for suicide relapse, scanning EHR data, medication compliance, things like that. This is in also wearable form, right? So things people could be wearing. AI can be streaming workflows that are being used for that. Prioritizing inboxes, right? So summarizing maybe what patients send in an inbox and then feeding that back to the clinician to make decisions from there. Some of the benefits that we know from AI in healthcare, reaching patients in rural or under-resourced areas, reducing administrative burden. Maybe we could argue providing client support or patient support when physical clinicians are not available. But as we've spent a lot of time kind of debating, there are limitations and risks. So most of the AI tools are not FDA cleared, or FDA approved. We have several states that have come out with laws against using AI in therapy. Illinois, where Dr. Best and I are, being, I think, the first state to do that. So there's safety concerns, as we know. There have been several stories in the media of high-risk folks using ChatGPT, becoming somewhat dependent on it, being led down pathways for self-harm and suicide. There are bias and equity concerns, privacy and HIPAA concerns, obviously, right? And then there's this like existential question about our profession. Are we being replaced? So there's that too. Best practices, I'm going to skip. I think that's something we can kind of talk through. But this is just a very exciting and interesting time right now. Dr. Best, do you want to share kind of the pilot project y'all are working on and how that's been going?
Sure. So we recently contracted with a third party, Avo AI, I believe is the name of the company. We use Metatech Expanse, which does not have an integrated option for us. So we had to go out for a third party vendor. We have been very hesitant, sort of administratively, but also from a provider leadership standpoint in a lot of AI integration for a lot of the reasons that you already mentioned. So in our sort of IT governance committee, we decided to use it sort of as a fancy transcription service, for lack of a better term, first, where we use a phone as sort of an ambient listening device, getting consent from the patient. And then it sort of listens in the background as you proceed through your encounter with the patient. And then we're basically only using it in the HPI section, so the initial history section, and then in the assessment and plan section to sort of aggregate the conversation. So again, we're not using it for clinical decision support. We're not using it for order entry or anything along those lines right now.
How long has the pilot been going on?
Probably 6 to 8 weeks.
Okay, so
Yeah,
it's
we're pretty fresh along in the program.
what do you think?
Um, when it when it works well, it's extremely helpful,
Okay.
especially in a predominantly primary care setting, where we have a lot of back and forth. So I'm general pediatrics, so I'll often have a parent or two and a sibling in the room, and it seems to be able to pick out the pieces of the conversation that are relevant to that specific encounter, which is pretty impressive. Um, there is a significant amount of editing that we still have to do with the content that's produced by the AI system. So from an operational standpoint, what I do is you go in, you get consent from the patient for what I say is an AI dictation service, because that's essentially what we're using it for. And then I come back and sort of look at what it's aggregated, and then oftentimes have to edit and then sort of copy paste it into the actual EMR. So operationally not ideal, but it does save a significant amount of time, especially for those providers who will save their documentation to like the end of the day or
Oh,
when they
yeah.
break in their office. My practice has always been to document as I move through the visit. So I have not seen the same type of time benefit that a lot of our other providers have. One of the more every once in a while it'll do something weird. So the AI company calls those hallucinations. I think someone alluded to that in the chat, which I find to be kind of funny and extremely creepy all at the same time.
Yeah.
Artificial intelligence has hallucinations. So every once in a while we'll run into that type of thing, but it's less than 1% when that occurs. So for the most part, I feel like it's been a pretty successful pilot. We're planning on rolling it out to more providers probably within the next month or so.
This one seems to be one of the most frequently used, like the most frequent use cases for AI that I've heard of in medical care is the note taking. It's kind of what you're describing.
Yeah, I sort of feel like intellectually it's the easiest leap
Yeah.
because as a profession we've used dictation services forever. So it's an easy psychological step, I think, to get
Yeah.
people on board. It also keeps you integrated into the decision-making support. It's not suggesting a diagnosis, it's not calling the ball on a treatment course. It's just sort of allowing you to look at the data that you extracted from the patient in a little bit easier of a format than just trying to remember what was discussed or in just like a blanket transcript.
Yes, right. Which probably for those clinicians who wait till the end of the day, like you described, that's like they're probably so relieved.
Yeah, in fact, I will probably within the next few weeks, one of our general pediatricians that we work with, that's her typical practice is to wait. And it is significantly contributing to her, I think the current term is cognitive load. We used to call it
Yeah.
burnout, but now it's cognitive load, right? So I'm actually going to probably be handing my license over to her within the next few weeks because she and I share office space, and I can literally see her pulling her hair out on her days off.
Yeah.
And so I think so we're probably going to use it a little bit more selectively. So instead of purchasing licenses for the entirety of our clinic providers, we will probably look at people's practices and then give the AI assistant to the people that we think would benefit the most from the time save.
Okay. Right. So like being strategic about
Who we apply it to, right?
yeah. Is anybody else using this kind of tool in your practice? If you don't feel comfortable coming off mute, you could just throw it in the chat. I'd be interested to see if anybody else is using AI in their work right now. Not yet. And Karen, we see your comment. So it seems like you are using it. If you feel comfortable just explaining what you mean, because this sounds really interesting. On
Okay,
information. Yeah, thank
sorry,
you.
I'm on my cell phone. It took me a minute to come off of
Sure.
thing. So no, not using it in a clinical sense of taking notes. Often use it to crunch data, like when you said when you were preparing for this.
Mhm.
And one of the things that I learned is that AI is actually really good because once it spits out the information or creates a summary or whatever you've asked it to do, depending on the prompt, it's also, you always want to read over it and you want to look for, just as you would look over a note that it created for you off of a patient visit. But I always look it over to see if it kind of clocks, like it doesn't make sense.
Mhm.
One of the things that I've found helpful, because I'm so often using it to gather and get us started in conversations or with presentations or with trainings, is I'll literally ask it, what hallucinations, learning limits, or oversteps might you have created, might have been created in what you sent me? And it will literally then list out, my last learning date was, January of 2025. Any information that's come out since then wouldn't be included in this. There are several studies that, lend towards this, but when I reported out that it is exceptionally more effective than X, Y, or Z, the word exceptionally may have been an overstate. It has been shown to be more effective. Exceptionally may have been an overstep. So it'll give me some direction of
Wow.
where to look. And I just kind of put it through its paces as I was learning AI and learning its limits and learning how to use it. And I'm new to all of it, so I'm not putting myself out there as an expert by any means.
Sure.
But I have found that when I got that suggestion is, hey, ask it to predict its own hallucinations. I'm like, ooh, let's play with that. And
That
it's
is
been
so
remarkably
cool.
helpful.
Yeah, thank you. That is so cool. And also like what are the oversteps, overstatements of, kind of the word exceptionally might be too much of an overreach. That's really cool.
Yeah, exceptionally widely, widely
Yes,
accepted, widely used, very common versus it appears to be more than 50%, that kind of thing.
that's awesome.
Hi, everybody. This is Roger Kessler from the Dartnet Institute in Colorado. And we have a very strong focus on utilizing AI in the process of identifying risk, turning that risk into communication with the primary care physician, care planning, and care management, with AI supporting all of that. and we are probably a quarter away from every time a chart is opened, an EHR chart, and we're talking about non-epic independent practices is our focus. AI does a sweep of all available data related to the presentation of the upcoming visit with the patient in real time and creates a data summary of all available data and summarizes that for the PCP and the patient at point of service. So that's our first major effort. The second thing we're doing is we are regularly collecting what I consider to be the most important domain of measurement in primary care and behavioral health, which is quality of life, patient-reported quality of life measures. So that data and all social determinants data and EHR data and lab data, blah, 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 is going into a database from which we are trying to develop a predictive algorithm that identifies those patients in a panel that are most at risk of poor outcome, non-engagement, blah, blah, blah. And using a DPP model, diabetes prevention program model, we're saying if we can identify early and intervene early, we can impact on the course of disease. So that's the work that we're doing at the moment. And if anybody's interested in it, we love to collaborate because I don't know what I'm doing. I just keep pushing through and coming up with these things. So that's what we're up to.
Wow, Roger, thank you so much for sharing that. So I have so many questions. I'm sure many of us do. So the first thing you mentioned, the visit summary, sort of like prior to the patient getting into the visit, the clinician and the patient's provided a summary of anything related to that. Is that what you?
No,
Okay, okay.
AI provides that summary.
Oh, right. Yeah. But can you give an example just so I could sort of track?
So one of the areas that's most frequently underobserved and underintervened with is the presence of multiple chronic diseases. And so, for example, part of the summary is designed to identify potential interactions with the medical presenting problem for that visit with other issues in the multiple chronic diseases. It also will track things like if there are notes that suggest patients had a particular problem following through with the medication regime, whatever. That's another example of it. If there are behavioral factors identified, then that becomes part of the summary also, and also whether they're being intervened with. So, it's going to change a million times,
Sure.
but that's the path we're down.
Awesome. Do you know what you're using to do that? Did you purchase something?
No,
Okay.
our read of the predictive algorithms for risk in primary care is most of them were not normed on US populations.
Mm-hmm.
Or if they were, they focus on outcomes that are not terribly relevant to improving health status and function. So they may predict rehospitalization, they may predict, higher levels of mortality, they may predict, all these down the road issues that are critically important, but they don't predict which patients need something different now.
Mm.
So we're having to develop that ourselves.
Oh, that's very cool. That's awesome. Thank you. If anybody has other questions for any of our speakers, or if anyone wants to share how they are using AI in their practice, we'd love to hear it.
We are not doing as much sort of macro level AI, but I think some of our clinicians are using it as interventions in behavioral health to have patients have sort of in between support between their appointments to use ChatGPT for journaling prompts and to use it for self-reflection tools, help me understand why these patterns exist.
Yeah.
And a lot of patients have said, I don't know if I should tell you this, but and we're like, that's really great. If it's helpful, it's helpful. So in the clinical sphere, just hearing back from patients, but not necessarily using it as like a practice tool. So I'd love to get some, documentation, like Ian was talking about aggregation, like during an appointment. And I don't know if Epic is working on some type of feature with integration there, but would be cool for that to be like worked into the EMR as well at some point.
Awesome. Yeah. Thank you.
Yeah, it's interesting. So I sort of feel like the way that we're using it and the way that you just mentioned is baseline. And then I think the way that what Roger's discussing is it sort of should be the goal. So the ultimate like assistance, right, is we have so much data that gets aggregated into one location in the chart in the EMR, but now the EMR pulls from every ER visit and every immediate care visit and every specialist that they go to, and that data can all be pulled in. But then how do you, when you're doing chart prep prior to a visit, especially as, again, my own personal experience as a primary care provider, I mean, I take care of kids, they don't get that sick. I can only imagine what it's like for my family practice and internal medicine colleagues. It takes time to find that. So that end state that Roger's discussing, where you can have something, move through the chart and help aggregate all of that data, I think that kind of makes the next leap in sort of how it helps you actually deliver care to the patient. I know the company we're working with is discussing that, but I think it's very much in its infancy.
Right. So like baseline, we've got tools that can summarize notes or maybe like help with the inbox management, but then the next level up is the predictive algorithms for identifying risk. And then what can we do to intervene? And Rachel, I'm so happy that you brought up the patient client side of things. I would love to hear from people on how you're working with your patients and clients that are using ChatGPT, and if that's come into psychotherapy or behavioral health appointments. I've had a few clients act really similarly, right? Like I'm using ChatGPT to work through this problem or this anxiety, and they've been like afraid to tell me that. So I wanted to give a couple of examples. I had a client who was worried that their parent was going to find out about something they did, and what should I do about this? Right. So this client had a whole conversation with ChatGPT around this issue and felt pretty reassured about it. And this was in between our sessions. So then we sort of talked about it. And then I have another client who's struggling with, I would say, some eating disorder, or definitely eating disorder behaviors, eating disorder diagnosis, who's using ChatGPT to sort of compulsively check calories, workout plans. And this client has insight into this, but I'm still trying to understand, like, how do I as a clinician talk to clients about this? I think we want our clients to tell us that they're using it and what for. But would love people's thoughts on that, if that's also something that you're working with or have encountered in your sessions or in your medical appointments. Obviously, medical probably always does, because people are constantly Googling everything all the time anyway.
Yeah, from a medical delivery standpoint, the term I use with parents a lot is you need to curate the online experience for your
Yeah.
children, right? So you wouldn't allow them unfettered access to the internet when they're 11 or 12. You shouldn't really necessarily allow them unfettered access to AI bot, ChatGPT decision making either. So that's the conversation that I have a lot with parents and especially with teenagers is be wary of the algorithmic social media, be wary of how you're using these things. And before you take action on any of the things that Chat GPT suggests you should always make sure you run it by either me or your parents or a friend who's not involved in those conversations, just so
Mhm.
you have, you know, some human filtering that occurs.
Okay, that's super helpful. So because you're mostly working with kids and adolescents, I'm assuming, right?
Correct.
Pediatrics. So you are suggesting ways to sort of keep themselves safe for parents to continue to monitor that use
Right.
and make sure you're like running it by a human being.
Right. Yeah. Telling, so the analogy I use is telling a teen or a preteen not to use social media is the equivalent of telling, you know, a guy that's been smoking cigarettes for 60 years that, oh, he should really stop smoking.
Yeah, yeah.
Right. They intuitively sure, but
Mhm.
they're not going to stop smoking, probably.
Right.
Right. So it's the same thing with teens and preteens. If they have access to it, it will be utilized.
Mhm.
So telling them to abstain in a variety of topics is never necessarily a good medical thing to say. But so you try to give them some quick cues, some quick guides on how to utilize it in a safer fashion.
Yes, more of a harm reduction approach, like assuming it's going to be used, but how do we do it safely? Yeah. Kelly in the chat, you've considered but hesitated based on feedback about what the AI tool in our EMR could handle and concerned it wasn't a good fit for BH. Curious what AI ambient note taking anyone else is using. Kelly would love to know what the concerns were of why the tool wasn't a good fit for BH. That could be helpful for other people to hear as they're considering using tools, if you wanted to share more about that.
Sure, I can come off mute. So the feedback we got from our EMR was that and the tool that's integrated with our EMR is Suki. And it was just saying that it could only handle in the way it's in our EMR short snippets of information at a time. And then we might have to wait for it to catch up, and so we were concerned based on and kind of what they were telling the person that was exploring it for us, that it was going to cause a lot of awkwardness in the flow of conversation in our visits. Not to mention, and I like the idea. We weren't sure, first of all, how patients would feel about using it, but I do appreciate, the feedback of understanding it's just a dictation tool. But mostly we were just concerned if we're having to pause and wait for the ambient listening to catch up, then it was just going to really throw off the content of our sessions.
Yeah, it kind of throws off the rhythm of the visit when you're trying to get it to catch up. So
Mhm.
our system does not do the AI processing until you end the recording. So it records the conversation, and when you end the recording, then it applies the AI filtering or whatever the term is, and then gives you the output afterwards. So we're not watching it do it in real time. We're editing after the fact. So you might want to look at a system that does it that way, so you're not having to pause and stop and wait for it to come.
Yeah, that's why I was curious what other people are using, because I do see where it would be of benefit for us, but if there's a better system out there and that we could look to, um, that would be helpful to know if what people are finding works for behavioral health.
I have the option to use it through Simple Practice for private practice, but I haven't tried it yet. So in oh, and Dr. Best, did you mention what system you're using?
Yeah, it's called AVO.
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 I'll put it in the chat. AV, what was mentioned was AVO and Suki. DAX, Dragon Ambient Experience works well with Epic. Any kind of, this is for anybody, Dr. Best included, any comments on how patients have reacted when you've said that you're using the tool or the tool is going to be listening in on the session?
I have yet to have anybody say no, thank you.
Okay.
I also benefit from having been in practice for a while, and most of my patients are established, so I already have a very good trust relationship built with people. So, but even parents that are bringing in newborns or that are transferring in from other practices that I've used it with have not really offered any significant objection. I'm also very deliberate in my phrasing that it is a transcription tool because that's how we're using it. So I don't think there's any concern for them that it's going to be, superseding judgment or anything like that.
And I would wonder, like, I guess the company holds that data. Do you know if they retain
They retain, I think they retain the transcripts for like 14 days.
Okay.
Or something like that. So it's not held for very long. And I've not asked why this is, but my assumption is for legal reasons. I mean, it's HIPAA compliant and all that kind of stuff. That it's intentionally excluded from the EMR, so you have to take it and physically put it into the note, which I
Okay.
suspect absolves them of some medical legal liability.
Yes. Okay, that makes sense.
It should be noted that different AI products have different rules about holding the data. So whichever there's not a generalizable statement that says all AI products hold it for X number of days or Y number of days. So whatever product you're using, take a look at that. There are some products that hold the data for a remarkably short period of time, and then it's gone. And there are some products that maintain a database of the data. So take a look at that.
That's a great point.
I'll jump onto that as well. Using DAX, they say that they hold on to the recordings for about 2 weeks, and then they delete everything but about 1 to 5%. I can't remember the number exactly, but they don't say exactly what they are holding on to, whether it's what information that's part of that that recording might be maintained, and that's they say that it's used for future training.
Yes. That's great.
I would say that
Go ahead.
I would say that I utilize for my psychotherapy practices, I utilize twofold for note summarization for patients, and they like it because it helps provide them with a timely feedback on what was discussed throughout the visit. It always summarizes what was discussed for me and for them, and I go ahead and push it over and email it to them. I've had very few patients say no. Might have happened, I want to say out of 24 patients, 2 might have said no, and that was their first time meeting me as their therapist. The initial visit, they said no, but going forward, as they built trust in me and a relationship, they were agreeing to it. But very transparent about how this is a transcriptive service to utilize to help with the note taking, not to make any clinical decision making for their treatment. So that I think helped build the trust with them as well.
So did you say that you send the transcript to them via email after the session?
Yes.
Wow.
It automatically, like in terms of, so it doesn't transcribe the visit, like it doesn't give me any feedback on what the transcription is during the visit, but 10 minutes after the visit is complete, it will provide me with a summary to be able to provide the patients. And I can just push it, say, do you want to send, is it accurate? And it say yes. So
Right, like it provides a summary, not a word for word transcription, is that right?
it's not a word for word for the
Got it.
transcription, a really good clinical summary of what was discussed throughout the visit.
Wow. Okay, that's very cool. Thank you.
You're welcome.
Joel says, which I'm glad, Joel, thank you. I think we need to talk about this too. What about providers who are intentionally not using AI or reluctant to adopt this early? And one, I'm glad we're all on this call because I'm sure we're on this spectrum together. So if somebody is feeling reluctant to use AI or intentionally not using it, would love to hear your reasons or your thoughts or your hesitations.
So I'm obviously using it because I'm in the pilot program, but we have had a number of providers who have said they're not interested. Some of that is because they don't particularly see the benefit of it for their practice for the reasons, the limitations that I mentioned. Some of them just straight up have said they don't trust it and they're not interested in advocating it for it with their patients. So that's been the hesitation that we've had in our organization. I'm not sure it's early at this point, unfortunately, with AI. I actually think that, I mean, it's rapidly moving forward.
Yeah.
I don't know how, I don't think we're early in the process when it comes to this type of stuff.
That's a good point. Right. Yeah. Early adopting and things like that. I think there's a lot of like a legitimate concern, right? A lot of I belong to a advisory group for ethical use of AI in order to make sure that we're sort of looking around corners with bias and who's, what types of patients are being trained on the models. So there's the bias component. I think there are sort of privacy concerns. I think there's a little bit of, I'm just sharing sort of what's been on my mind. When I think about using an AI note taker, this is speaking about my own personal insecurities, but that's like, okay, medical providers for a million years have been just, out there fully in terms of their interventions. Some behavioral health providers were just doing a lot of closed door conversations, and that feels like you're exposing your work, right? To have it all recorded and transcribed. I know a lot of students that I've worked with are very reluctant to use tools like that. And I'm seeing people in the chat kind of like feeling the same way. So I think there's a lot of concern. I have some other level concerns around people's attachment to ChatGPT. I have known some people to take text messages when they're dating someone early on and feed it all into ChatGPT to sort of get a read on the relationship. And I think that is an interesting use case, but I also find it to be kind of like ethically questionable, right? So normally those are some things you might talk to a therapist about. So I don't know. I think there's a lot of just interesting questions about it. If anybody has any others, and we're happy to sort of entertain those and hear what they are.
I can add something. This is
Yeah.
Mary from the Health Federation in Philadelphia. I think some of the questions that are important for me, I think, to ask is particularly around the systems that store data, that store the recordings. Who owns that data? There was one attorney I spoke with who mentioned it could potentially be discoverable as part of a patient record if the records were subpoenaed. And so I think that's just an important consideration and question to ask as folks are getting systems. Because I think what we document is not every single word necessarily of our visit. And I think, to just add that one of my hesitations specifically around that is that some of the things that are happening now in our country, like I know there's been a major health system in Philadelphia who've had all of their patient records subpoenaed by the federal government. And there are currently the hospital systems in litigation with the government trying to not turn over the data, but it's down to individual patient notes with their providers. So that's, the part of me that has some fear around where is that stored, who does it belong to, and who could have access to it is, I just think, an important consideration. There are definitely systems I've spoke with who don't store the data. And so, that's, for me anyway, something that feels much more comfortable.
Yeah, that's great. Thank you so much for sharing that.
Just to tailor off of that last comment, the legal and the regulatory environment is not keeping up with the capabilities of the systems in any way, shape, or form. And that should, before any system adopts any type of AI product, or even an individual adopting any type of AI product, especially used professionally, Like you just have to be aware of that is so far behind the current state of the technology.
Yeah, I think that, yeah, those are good points. I have so many thoughts running through my head on this. What else? Any other use cases or concerns? Patient. Carly says that they're wondering about how AI generated notes would be used in court for subpoenas, family court, criminal court. I have the same question, if anybody knows. Denise, do you want to come off mute and share your thought? It's an important one.
Yes, it is. Hi everyone. With them, from what I've seen, the demos and everything, I don't believe it captures the true humanistic side of the way a therapist documents what occurred in that session. It's more robotic and more formed, and it's not more authentic to actually catch what really occurred, or the goals, or the nonverbals, or
Yes.
things of that nature that we would document in our notes when we do our notes. I don't like formed notes because it doesn't capture. I don't believe that formed aspect is what the state means, or what, NASW really is stating when they say about taking on the documentation. I think they really want to know what happened and actually in that session, and how are we doing and progressing with that client, whether it's progress or stagnant or regression. So that's why I don't think about the note taking. But yeah, AI is okay to help form a letter or a note.
Yes.
Not a progress note, but I mean like an email or something like that to help grammatically, help you. But other than that, as far as an original thought, no, because it doesn't have a brain and it doesn't have a heart and it doesn't know our clients. So that's just my take.
Thank you. Thank you for sharing that. Yeah,
Thank
absolutely. I was hoping that we could touch on that too, because there is a little bit of like, when you write your notes, you are remembering, you're sort of like imprinting that memory and that progress as a clinician. So does it, and Dr. Best, like, does it impact your memory? Do you remember as well as what happened in that session or the vibe of it, if something else is taking the note?
I had all the empathy trained out of me in medical school, so it doesn't really.
You don't care?
I mean, in all seriousness, I mean, and so again, now I'm speaking more from the physician side of it,
Yes.
less sort of the therapy side of it. I mean, we are trained to be sterile, to be clinical. It's it's something that, as a physician, it's something that you need sometimes for clinical detachment purposes. But it is something that causes some shortfalls, I think, in how we care for our patients, and especially in the way we care for our patients with mental health challenges. So I appreciate Denise's comment about that. For me personally, I'm so used to a cold clinical note. And also, and you alluded to this earlier, physicians, we just assume that at some point someone's going to read our note out loud. Like that's just our legal reality, right? So the more precise it can look, the more cold and more deliberate and more objective it can appear, the better it is for the purposes of communicating medical information to the next provider that's seeing the patient. So our use case in the physician world and your use case in the therapy, behavioral health world are not necessarily the same when it comes to documentation.
Yeah.
So there's another conundrum for us to wrestle with. There is emerging data that says AI does a better job at remembering information and gathering information than individual clinicians. So I get the issue of the coldness of the note, and it doesn't capture things that it can't capture. On the other hand, there's fairly compelling literature that suggests that lack of access to available information is a large cause of medical error.
Yes.
So some place or other, there has to be this melding, and I'm not smart enough to figure this one out. Oh, I think my dog has just figured it out. How do we meld the nuance of the clinical issues that we want to communicate with making sure that all the information that's important and necessary for clinical decision making is brought to the fore? I don't know how to do it.
Yeah.
I'm counting on you guys to figure out how to do that.
No, it's just such a good debate, Roger. So I'm glad you brought that up, and I'm glad Denise also shared, because sort of the clinical instincts, the gut, right, the inexplainables, but probably AI is better than us at remembering and documenting and categorizing, so we can reduce error that way.
And
I think that's, I'm sorry, but I was just going to say, I think that's, one of the things I get prickly about is when you see these AI tools coming out purporting to be an AI therapist. And it drives me absolutely crazy, because title protection says you can't call yourself a therapist without a license. And therapy is an art form. And, what Denise is talking about is the art of providing therapy. AI note taking is a data capturing tool. And to the extent that notes are about conveying data, awesome. But it's not going to convey the art of what we do, nor is AI ever going to replace the art of what we do.
Roger, you got something?
Well, this has been a brilliant call, and a really important call. And I've been looking for a group like this to have these conversations with for a long time. I have two secondary reasons that I want to share with the group for being on this call. The first is my colleague C.R. Mackey, who's on this call, and I are editors of the journal Family Systems in Health. And we would love to do a special edition on issues related to AI, IT in behavioral health integration. If anybody has any ideas about either taking on a special issue as a guest editor, or wants to make a contribution, please reach out to either of us.
Awesome.
That's one thing. The second thing is, we love the group, the group that's part of my team, and it's 4 small independent practices, and it just ain't big enough to really pursue all the things that we need to pursue. So we would like to recruit 15 more primary care practices, hopefully many independent practices, but some organizational practices, to become part of our collaborative and work with us on the focused discovery on what's the best way to use AI and IT to improve primary care and primary care delivery. So if any of you guys are from a practice that just wants to push the edge of these things, please contact me, and we would love to have you part of it. The last thing I want to say is this conversation can't end. Stacy, you've created a monster. How do we figure out a way to identify the set of people on this call for whom these are really sufficiently important issues that amongst the 150% of other things that we have to do, we could form a work group to just talk about these things on a regular basis and figure out ways to pursue it. I don't have the bandwidth to organize that thing. I don't know if APA can help us organize that thing, but this is too important of a group to just hang up and the thing is done.
Right.
That's my idea.
Awesome. Thank you so much, Roger. Lots of opportunities to collaborate And Roger and CR put their information in the chat. As far as a work group, we can pop that back up to CFHA and see if that's something that we can do. But I completely agree that if I could, sort of leave you with one thing, I would say lean in to this. Like Dr. Best said, that we are not really at the beginning, even though sometimes it feels like it. And if you don't enter the conversation, there are so many more people that are frankly not as qualified that are already pushing these things forward. So if you know anything about, healthcare startups and kind of who the types of folks and the types of training that those folks have to do healthcare and mental health startups, typically some clinicians, but we can always use more clinicians and actual practitioners involved in these conversations. So I would say don't shy away from it.
And the only other thing I'd like to add is I'm having experienced AI like in my office. I'm not particularly worried about it taking any of our jobs anytime soon. And I think the one caution as AI advances in the healthcare space is, it doesn't know what it doesn't know, and it's sort of programmed to provide you with, the likely scenario, the common scenarios, but everybody who works with patient knows it can take multiple encounters, multiple visits, multiple sessions to really distill down to sort of, I don't want to say fix the problem, or for me to like make the accurate diagnosis. So there's at least in current state, maybe in 15 years it'll be different. You're always going to need a human filter in place to do the actual sort of data crunching and that final determination of what needs to happen next.
Yes, right. So you think of it more as like a companion tool rather than replacement.
Yeah, I don't, and again, I don't know what future state looks like, but even, I mean, I'm not above using, Chat GPT, like when I don't know what's going on with the patient to suggest possibilities that I haven't thought of.
Yeah.
But I mean, one of the potential dangers I see is if you train it to spit out an answer, and it spits out an answer, even if that answer is 90, 95%, 98% certain, it's that last percentage where you really need the human brain still to figure out what else needs to be checked, what other labs do we need to order to make sure it's not that 2%, or am I comfortable putting my name on that recommendation and saying, yes, I think this is correct. So I came away with the experience in the pilot project feeling like, oh, well, I mean, I'll at least get to my retirement without being an AI.
Yeah, for now. Right. Yeah, and I think for those of us kind of talking about replacing therapists, if you've actually, I've messed around with trying to use one of the chat bots as like pretending I was a client and throwing some issues at it. And I don't know. I don't, I feel like it can do a good job with maybe some subclinical stuff. But the magic is in the actual behavior, right? So that's something also to consider. The ChatGPT can list a bunch of ideas and insights and stuff like that, but the person actually has to go out and follow through on some of those things, right? So I would love for us to just keep working with our clients and patients on understanding how they're using it too, so that we can, meet their needs and put some safeguards around it. Denise is asking, would you describe the qualifications? What would be the criteria for the qualifications? I'm not sure what.
You were saying in regards to the build of adding more professionals in regards to identifying, and you said there had to be, the qualified individuals who would be competent enough to, or qualified enough to participate in something like that. And that's what I was referring to in regards to the qualifications and what criteria, guides that qualification, what would that look like as
For,
to somebody being qualified to be in that role? That's what I'm saying.
Are
As an
you,
executive director, I'm the founder and executive director of a community nonprofit that's been around for like 14 years. So I was just asking to get some clarification.
from like what Roger had said?
Yes, ma'am.
Yeah, Roger, are you looking for specific qualifications?
I'm looking for organizations that are primarily, but not exclusively, non-Epic users, that have organizational and administrative leadership and support, and have clinicians that are interested in participating in this. Our team is comprised of family physicians, practice administrators, practice IT specialists, researchers, AI builders. And believe me, it took 2 years of those folks meeting together before we were able to have useful moving forward conversations.
Mm-hmm.
So, but on the other hand, you can't do it without that kind of team,
Right.
you know? So a number of years ago at CFHA, Brenda Catry and I did a workshop on IT. And one of the things that she did is went back to her AI director. No, at the time it wasn't AI director, it was the IT director. And he literally made a video of how to talk, how clinicians can talk with technicians, AI people, IT folks. You know, there are just different colliding worlds. And if you want to move this thing ahead, you have to tackle that head on. And I personally don't think of a way of getting that done except by putting the kind of team together that I just described,
Mm-hmm.
if that makes any sense.
Yeah, that's great. That's great. Okay, my friends, this has been an awesome conversation. We are at 1 o'clock Central Time, so that's all we've got today. Thank you so much for being here. What a great conversation. Please have a great rest of your day. Dr. Best, thank you so much. Roger, thanks for contributing, and everybody who jumped on the call today. Have a good rest of your day. We'll see you for the next one.